All right, welcome to Unpacking the Complexity Evidence's live Q&A with Tina Price. I'm excited for you guys to be here and most excited to have a chat with Tina, who I've followed actually online on Twitter. Got introduced to her from her physiotherapist, my colleague and friend, Matt Lowe. And hopefully by this time you've watched her presentation, which is an awesome presentation. I think if there's one thing, and I'm going to bother Tina to see if she'll let me show that presentation to some of my physiotherapy students in training, because I think they'd benefit hugely from that. But a really great perspective from a patient, and I think she does a great job of encapsulating what it means to bring the patient's context into the room and what it means to really respect and listen to the narrative of the patient and let it be a huge component of your patient care. But before we get into a huge amount of discussion on that, Tina, would you mind introducing yourself a little bit, maybe a little bit of background, what you're doing? You talk a little bit about it in your video, but maybe a little bit of kind of where you're at, what you're up to, and professionally, and then maybe a little bit about your work on your Living Well site. I think folks would benefit from hearing about that.
Brilliant, thank you. And thank you, Mark. Thank you for the wonderful introduction. Yeah, my name's Tina Price. I'm a person living with persistent pain. I was my background profession is teaching. I've taught primary, secondary school children and ended up teaching special educational needs, which is just amazing and a huge privilege. About 11 years ago, I had a manual handling injury, and that's where my life started, living with persistent pain. I basically, after my injury, I was in pretty bad way. My condition was quite severe, really. I had a prolapsed disc, my sciatic nerve root was compressed, and I lived with severe neuropathic pain and lower back pain. I carried on teaching for a year or two, eventually decided, actually with some professional advice from a physiotherapist, that perhaps that wasn't the wisest idea, and switched my role to part-time self-employed role, and I work with young people with special educational needs and people with other disabilities, physical disabilities, mental health disabilities, and so on. So I am hugely privileged to work in that domain.
Yeah, no, it sounds like a rewarding work that you're doing. And can you tell folks a little bit about, because you have a blog and some work you do, kind of advocacy work with the patient voice and kind of your sharing of your voice and your experience, because I think it's been valuable to me and some of the other presenters, Jerry Durham and others, who have really leaned on that to kind of better understand the patient perspective. But you mind sharing a little bit about that with folks?
Yeah, so I run a blog called livingwellpain.net. I haven't been running it very long, so I think it's about 18 months now. And it was actually following a suggestion from Matt Lowe that actually he felt I had some insight into my own condition, and maybe that insight might be useful to be shared with others. So it's a blog that's aimed towards clinicians and towards patients, and my aim is just, if it can be of any help, if my insights can be any help to anybody, then that's absolutely great. And I've been lucky, so I've become on the executive board of the UK Physio Pain Association, and I've started to become involved with some pain research projects and so on. So yeah, huge honour. I've met some amazing people along the way.
Yeah. No, and I think we need more of Tina's, and we also have Gilletta, who's contributing to this project, and others who are sharing their voice. And I think, honestly, and I'm trying to work towards more and more of it, but having patients as part of our instructors in physiotherapy undergraduate or graduate coursework, and then even in our post-professional courses, weekend continuing education courses, because I know I can speak for myself and Matt and others that I think some of the best learning has happened from listening to the Tinas and the Gillettas, and really understanding where that component of things falls within best practice. And that's what this project's all about, is really maybe looking at what evidence is capable of, where it misses short, if we're just really focusing on, what evidence, traditionally was, which was very research based. And not to say it's not important, but I think we need to frame it in a big perspective of patient care and working with human beings, which can be a little bit more gray than the black and white world that research tends to paint or attempt to paint, as far as clinical decision making and all that good stuff. But
yeah.
Any other, before we get into anything more, let's just start a little bit before your surgery, because one of the things you mentioned in your video is it took 17 months, I believe, or somewhere in that ballpark before, from like injury to where you had this procedure. And it sounded like it was a frustrating 17 months because, of course, and you have understandable, thoughts of, well, what if I had that surgery earlier on? Would it have, salvaged some of the sciatic nerve and prevented some of this? And I mean, understandable thoughts that you have. But what do you think was the big missing piece in that early 17 months that might have helped you maybe navigate that more quickly and maybe get to the treatment that, ideally would have helped you sooner? Anything that you think, I know you mentioned some suggestions for healthcare, but I'm just wondering if you could kind of reflect back to those 17 months of it may not just be physio. Obviously you went through a variety of treatments and different things, and seemed like there were some missing pieces from what you mentioned.
Yeah. So I think the biggest thing for me, reflecting back on why it took 17 months, was actually coordination of care. So I had lots and lots of different clinicians, rheumatologists, physiotherapists, GPs, consultants. I had loads of them. And I suspect, and I don't know, and I don't criticize what happened. I don't think that there was anyone actually taking a good look at what was going on with me and for me and in my life. I think it was more, I went into an appointment and I was dealt with in an appointment, and I might be recalled back. But there wasn't anybody properly looking at the whole big picture and properly looking at what was going on and whether things were working or not. So I had a lot of treatments that were repeated, even though they didn't work. So for me, that was the biggest thing: coordination and lack of sharing of information. But there were some others.
Yeah, and we'll probably talk a bit about those as we continue today. I'm just, we have, and you mentioned in your talk too, some of these like guidelines and clinical guidelines and different things. Where do you think traditionally, if we just are strict guideline followers, and I know you're pretty well versed in it in your studies and different things, do you think the guidelines meet person-centered care? Like, I mean, if guidelines on their own, and you mentioned some things of some weaknesses maybe of guidelines and different things, but I'm just curious, like, it sounds like your narrative was on the outside looking in on these guidelines in action as far as trucking through these different pathways and different things of care that didn't seem to really touch on your narrative. I'm just curious your thoughts on that.
So yeah, no, I don't think, looking back on my experience, guidelines didn't work for me. As you know, I'm not a clinician, so I haven't got the ability to be able to point to exactly which part or whatever. But my patient impression is, no, they didn't work for me. The guidelines at the time, my predominant pain was neuropathic pain, and I think the predominant suggestion for neuropathic pain on the guidelines was medications, but I've got huge difficulties, huge sensitivities and so on with medications. But to be honest, medications would never have improved my life. It would never have helped me to learn to live my life well. It's almost like a sticking plaster, isn't it, that just goes on for a short time. And the low back pain guidelines, it just didn't work for me. So for me, guidelines are important, but I need a clinician to look beyond the guidelines. I need them to use it as a tool in the toolbox, but not the whole toolbox, if you understand what I mean.
No, I think you bring up some good points, and some of the things we try to, hammer across when we're teaching, as far as that, guidelines. Because you mentioned some great points in your talk, that you often fall in the exclusion criteria of the majority
Yeah,
of studies that they use to form these guidelines. So, right off the gate, your
yeah,
your your condition doesn't well fit with what they use to develop these guidelines. So those guidelines can fall flat. The other piece that is, I'm not aware, and there may be, but when we talk about clinical guidelines, are you aware of any that have any semblance of like patient input into them, like as far as besides just obviously distilling our randomized controlled trials and systematic reviews and all these different things that they try to do? Are you aware of any that have solicited, patient input and use that as part of our guidelines?
um, I don't know, to be honest. In terms of MSK, I've been involved as a carer in terms of NICE guidelines with mental health, young people with mental health. So I know that in the UK they do involve patients, carers in some sort of way. Um, but the trouble is, it there. I, as I said in the video, really, who I'm not sure that I would ever be asked. So because of all my exclusion criteria, because I've lived with persistent pain for so long, because I've had back surgery, because I'm very sensitive to medications, because I've had so much physiotherapy, whatever it is, I don't know that I would be the sort of person that is inputting into that. But it needs to be, doesn't it? It needs to be the full range, not just one or two patients. It needs to have a much greater patient input. But I don't know how you get around that.
Yeah, I think right now in those type of guidelines, just from my perspective, patients tend to be just data points, and that's how they exist in them. They don't really
Yeah,
exist as humans. They don't really, the human condition that surrounds that data point that they present
yeah,
to a researcher, I think is a grossly missing piece, and one that, especially when you're working with persistent pain conditions, and I'd argue in pain in general, that oftentimes it's that narrative that's going on around the condition that can really dictate, whether somebody's moving in a more adaptive direction or more maladaptive direction. So it would be interesting to see if they would do more consumer based components of clinical guidelines, to actually have the people these guidelines are being applied to, the consumer, be part of the driving force of maybe how they're applied. And
yeah.
but it
But
would take a research situation, because where do you see the limitations of really quantifying pain and trying to quantify things through effect sizes? And I know I'm not going to get too nerdy into all these nerdy research things, but um, versus the qualitative part of the experience, which is harder to put a little objective finger on, because the objective quantified part is what really often is the foundational pieces of these guidelines and research and things. Yet when we talk to people
yeah,
like yourself and others, we find that the qualitative piece and the subjective
yeah,
and the lived experience and the narrative is a huge component that you ascribe as the big piece that was missing. Um, what are your
absolutely.
thoughts around that, as far as when it comes to like guidelines and maybe best practice and evidence-based healthcare?
So I mean, as soon as you talk about um, that, then I immediately think of the 0 to 10 pain scale and so on, which I absolutely hate and loathe, because what does it actually mean? And how can I tell? I've lived with pain 11 years now, every day. But how can I tell how my pain compares to somebody else who's got similar diagnosis and who also lives with pain? It is very subjective, isn't it? And even if there were two people who had exactly the same pain levels, which isn't possible, then one person will be living well with it, and the other person will be finding life much more difficult. Um, but it's having pain is one thing, but it's the way it impacts on your life. It's the way you can continue with your life that is the most important. And that's not in there, is there? There's nothing about that in guidelines. There's nothing about, well, maybe there is, but I don't think so, about how to improve person's ability to live with it and to continue to contribute to society and everything else.
Yeah, and you'll see pieces of biopsychosocial and talk about psychosocial screening and different things and maybe some guidelines. But when it comes to the skills of interacting and creating that shared narrative, man, it's not really present. And unfortunately, I don't think a lot of professional training programs, physiotherapy, chiropractic, osteopathic, others don't really, I think, arm clinicians to have these skills. And I hate that they're called soft skills, but they're hard because you're digging into some narratives and stories that are very tough, challenging journeys like yourself that you've made to get to where you are. That can be, you're dealing with emotions and struggles and things that aren't nice and black and white. So,
but it's interesting as I reflect back on the first 4 physiotherapists that I had in the first 4 episodes of care. I still think that actually they probably had the personal skills, because a lot of it is about personal skills, isn't it? It's about being able to make relationships and being able to enable trust and empower and all that sort of stuff. But what I think went wrong was that their agenda, if you like, or what they thought they were going to be doing, wasn't that. And when the exercises didn't work or whatever, I found that I was just discharged to wait for an injection or discharged to wait for an MRI. Whereas if those people had actually used their personal skills and actually gone into it a bit harder and kept me on, then actually that story might have been slightly different. I don't know. But yeah, the shared decision making, therapeutic alliance is just hugely important, particularly if you're living with persistent pain.
Yeah, and that's, I just lectured in a physiotherapy student classroom yesterday about the narrative approach and different things. And universally, the students don't feel comfortable. And I'd say a lot of practicing clinicians talking about emotions, talking about things that are maybe not traditionally what you looked at as a physiotherapist, because we're going to question your tissues and we're going to interrogate things from this. We talk about this normative style of communication because we're taught these nice, neat, tidy algorithms and clinical prediction rules and different things that if we just question, we'll get the right amount of data that'll lead us to a nice, perfect decision. That's often much more questioned about, the objective part of your experience and like your aggravating factors, easing factors. Do you have certain clinical signs and symptoms that might lead us to a decision? Yet they don't necessarily question, well, how's this impacting you as a human, as a person? How's it impacting your life? Where I think that's a missing piece. So one of the things that you mentioned too in your talk that I thought was important to discuss is this paternalistic healthcare that you felt like you experienced for a good portion of your journey. I'm just curious, what if you can. Some people may not have a perfect definition of what that paternalism in healthcare or kind of a paternalistic style looks like, and maybe contrast that with what you felt was the better style of communication versus that paternalistic style, not only communication, but just maybe treatment and all that stuff.
So, so it's a tricky one to describe, isn't it? So looking back, and again, looking back to the first 3 or 4 physiotherapists, plus the other clinicians, I guess I was walking into a clinic and some of it was about me as well. So I was being a passive patient for all the reasons that people are passive patients. And I was being told what to do, and I did it. And it was as simple as that. And although I had some basic, simple explanations about my back and my discs and so on, it never went further than that. So it was like being told a recipe. This is what you need to do, and I don't know that anyone ever said, and you will get better, but that's the idea of it, isn't it?
Mm-hmm.
But when I started working with Matt, he had the skills and the ability, and I think the desire to empower me. So it stopped being about what the clinician thought would be right, and it was reflected back to me. Well, what do you think? Why do you think that is happening? And it opened up a new world of me taking control, rather than expecting or it being the case that somebody else would take control. Does that make any sense?
No, perfect sense. And I think you bring up some good points in your talk too about how there's kind of this wired in cultural factors of like, we're just trained as patients to just the clinician's word is the word that I go by, and I just follow directions, and I'm led to the outcome. And obviously the approach that Matt used and the approach that we're starting to see maybe is starting to work better is that more inviting the patient as as instead of like the fixer or the dictator of the whole clinical course of care. It's more that shared narrative, that guide, that partner in your care that I think's been missing for the most part in healthcare. Would you agree with that?
Yeah, very much so. I mean, I call it, I talk about patient skills, but I know that's not a term that clinicians particularly like to talk about. But I was brought up, if you go to a GP and they give you some medicine, you take the medicine. You don't necessarily know what it's for, you just follow it. And it's that needs to be broken in some way. Hopefully the younger generation aren't being brought up like that. I don't know. But at the end of the day, particularly if you're living in a persistent pain, disabling condition, then actually you can't have a clinician with you every day of the week. You can't access a clinician that often, really. So you have to learn how to deal with it yourself. So somehow that knowledge from the clinician needs to be imparted, and you need to be given the transferable skills to be able to sort things out in your own life and adapt your own life and become empowered to take over it. And I think I heard somebody this morning talk about taking control of the pain that you're in, rather than, I think for the first 4 years, I don't think I understood. I mean, naive as it may seem, I didn't understand my condition. I didn't, I just lived with pain and saw clinicians every now and again. Whereas now I've got a much greater understanding. I know, or I've got an idea of what might make my pain worse. I've got an idea of what might make it better. And it just enables me to live better with it.
No, that's great. And I think your talk and even our discussion just here has been kind of enlightening to myself, but hopefully it's been enlightening to the people that are listening as far as how that invitation and shared narrative and shared decision making and is a hugely important part of evidence-based practice. I don't think we can continue to have conferences and educational events and all these things where the one voice that really is the biggest important in the equation, the patient's voice, is just left out on the sidelines. And thankfully we're seeing conferences like the International Association for the Study of Pain, and I know you mentioned you're involved in some initiatives over there in the UK. I think that's so important to have that voice to really start bringing the humanity back to what is truly evidence-based healthcare, because I think, we give patient values lip service a little bit when we talk about, patient values are a big part of my practice, yet we then just go off into our own biased way because we don't really have those skills to how to bring that narrative in the patient's context into the room and co-create a context or a narrative with that patient. So if you were to, because I think we've got a great discussion so far, and if you were to give like recommendations to clinicians, and these could be early clinicians or maybe veteran clinicians, because I think we all share some of the same struggles when it comes to really truly evidence-based practice and what is evidence-based care. Because again, the patient voice being such a huge component that, again, maybe we should talk to our consumers about what we're offering them and maybe see if it's really meeting their expectations. But curious what your recommendations might be for clinicians who are trying to figure out where that patient narrative and how to better incorporate it into their practice maybe.
Well, the first thing has to be to listen to the patient, doesn't it? And to value the patient. So a patient's only going to tell you about the things that actually you probably need to hear if they feel that you're genuinely interested and genuinely curious. So that there needs to be some kind of genuine interest, and there needs to be some communication and relationship building, obviously. And I guess actually not to be frightened, so not to be concerned that, I mean, I've sat in clinicians' clinics and you know, I've been in tears because actually it's difficult to live with. And I'm not expecting the clinician to solve that for me. I'm not expecting anyone to fix anything, but to be a support along the way. And it's almost, I think, if clinicians maybe don't see themselves as fixers, but see themselves as enablers and supporters and sharing their knowledge to move forward. But the other big thing for me is to look outside the clinic door. So, you know, I live most of my life outside the clinic door, and to be able to support somebody to be able to manage their disability or their pain or whatever it is outside the clinic door, I think is hugely, hugely powerful. And the other thing, of course, is don't just look at the guidelines. Don't just do what you've always done. All the tools in the toolbox, and use the knowledge of the patient and the experience of the patient as well, and work together. Does that make any sense? Sorry, that was a bit long, really, wasn't it?
No, that is exactly. You got no arguments here with that perspective.
Oh,
I think. Oh, you got me now?
Oh, yeah, I got you now.
Okay. Yeah, no, I thought that was perfect. That's a great perspective, and I think one that clinicians will benefit from hearing for sure. So, Tina, I think we're going to wrap it up now because we've covered all of what I think we need to cover in regards to your talk. So, and don't worry, we'll edit some of this stuff out as far as the not hearing it and stuff. But I just wanted to thank you so much for your time today. Hugely appreciative of all you're doing over there in the UK and sharing your experience, because it's truly helping exponentially. Every clinician that hears this is going to impact a lot of different lives with the patients they touch. Hopefully patients are going to be able to hear some of this to see that maybe a different way of approaching their journey with pain, maybe one that can put them in more control and in a better ability to live well with pain, like you mentioned. And it's kind of the battle cry of your blog and all these great efforts that you're having. So thank you so much for what you're doing. Thank you so much for your time today. And I hope you continue what you're doing going forward.
Thank you. Thank you, Mark. Nice to talk to you.